Yeah, we can see that. Looks great.
Okay, great. Hi, good morning, everyone. I'm Sarju, one of the cardiologists in Boston area, and practice cardio-oncology in one of the Boston programs as well at Lahey Hospital and Medical Center. It's a privilege to work with International Cardio-Oncology Society, ICOS, and it's been a wonderful learning opportunities, just not for this COVID era, but in general. And without further ado, I'll get started. So, sorry.
That may be just some background noise. If everybody could be sure to mute their microphone, that'd be great until question time. Continue.
Okay.
So I will, this is Dan. I will add that Sarju just, thank you for joining in, obviously. And then Sarju just had a paper accepted in JACC Cardio-Oncology, and the manuscript version is available, but I guess they're still working on the official typeset document. Hopefully that will be available very soon too, but nonetheless, a very timely paper on cardio-oncology and COVID-19. So we're greatly benefited by Sarju joining us on the webinar today.
Thank you so much for the kind words, Dan. As we all know, we have been severely affected by COVID-19 caused by this SARS-CoV-2 virus, and it's one thing that millions are affected medically, but billions others are affected due to its social, economic, and psychological impact, and that's not insignificant, as we all are feeling the heat. However, while the COVID-19 pandemic is dominating the attention of the entire healthcare system, there are reports emerging that patients with pressing non-COVID related issues are not getting adequate or standard of care treatment, and that's concerning and will have a ripple effect, which may last longer than COVID. And so we need to look out for those. And to avoid that, that while we are focused on COVID-19, which is very appropriate, I think we also should standardize our approach in how we deal with non-COVID issues, especially for our most vulnerable patient population, such as in patients with cancer and cardiac disease. Because we know that people, from early data from China, that people with pre-existing cardiovascular conditions or the risk factors such as hypertension, diabetes, and obesity, as well as with cancer, they are at higher risk of getting infected, probably for a variety of reasons, and we will see that. But also they are more likely to face adverse outcomes when they get COVID-19. We know that people with cardiovascular conditions such as coronary artery disease or diabetes or even cancer, they were more likely to have more severe disease requiring intensive care unit stay versus the rest of the population. So this is a really vulnerable population and we need to look out for. Additionally, in general, illness-related cardiac issues, as we see with any other infection or severe illness, there are reports emerging of de novo cardiac presentations such as myocarditis, arrhythmia, and heart failure in patients without prior cardiovascular disease or significant risk factors. And although our understanding is so far limited, it is thought to be associated with the virus modulating ACE2 receptor, which is widely expressed in cardiovascular system as well, in addition to the lungs. And hence, we need to establish some sort of best practice document to best take care of our patients, but also minimizing the risk of healthcare workers. As I was just alluding to, this is the virus illustrated with the spike protein, and it needs the ACE2 receptor it uses it as an entry point and it is widely expressed in lung, which is one of the primary reasons why all coronavirus results in such a horrific lung injury and ARDS and respiratory failures. But it is also expressed in cardiovascular system, and that's why we have seen some reports from prior generation coronavirus such as SARS, as well as Middle Eastern Respiratory Syndrome coronavirus MERS, that they were also associated with cardiovascular injury in a short and long, both terms. This is the figure from what Dan was alluding to, our preliminary paper on this area. So we are proposing that the cardiovascular injury is likely multifactorial, and it is related to, of course, lung injury causing hypoxemia and stress-related cytokine release, which as a cardio-oncology providers, we know that from CAR T-cell therapy era as well, that cytokine release can cause significant cardiovascular injury. However, in addition to that, which is present for probably all patients with severe coronavirus disease, patients with pre-existing cardiovascular and cancer, cardiovascular disease and cancer are probably more prone to develop this, because as we know, cancer-related treatments such as chemotherapy or new generation targeted or immunotherapy or stem cell transplant or even cancer-directed surgery can lead to poor baseline physiologic reserve, and some of them can be cardiotoxic themselves, which can contribute to or make patients more vulnerable to develop cardiovascular injury when they have COVID-19. Similarly, patients with hypertension, diabetes, or pre-existing cardiovascular disease, they are also more likely to have it given the physiologic stress on an already vulnerable cardiovascular system. However, there is probably more to it, as I was alluding to, that this ACE2 receptor, which is widely expressed in the cardiovascular system, it is increased in patients with cardiovascular disease as well as hypertension and diabetes, or at least they are modulated in a way that makes the entry for the virus easier and more severe injury related to the entry of the virus into particular cell. And that, along with the weakened immune system in patients with cancer and those who have gone through its therapy, can lead to potentially increased likelihood of acquiring COVID-19, as we have seen so far from very preliminary data, and there is nothing definitive about this. But from an early paper from China published in Lancet, they showed that 40% people infected with COVID-19 had some sort of cardiovascular disease, compared to, and this is coming from the area where the general prevalence of cardiovascular disease is around 7 to 8%. So this is not representing the normal population from where they collected the data. In addition, the weakened immune system in patients with cancer or history of cancer and recent treatment related to cancer, it can lead to atypical presentation, and they do not mount typical immune response, such as fever, and this can lead to either delay in the diagnosis or misdiagnosis, and that may also end up in more severe disease. This is from New England Journal of Medicine paper published again from China, that the prevalence of these risk factors, cancer and coronary artery disease, was much higher in patients who had severe infection compared to those who had non-severe infection. And when you combine all these factors, as we do see in our cardio-oncology patients, they have some risk factors, pre-existing cardiovascular disease and cancer. This is probably even higher. However, there is no particular data suggesting that, but it is safe to assume that that would be the case. And this all can lead to the higher mortality in patients with cancer, CVD, and CV risk factors. And this is from WHO data from February, so this might have been updated, that patients with cardiovascular disease, its risk factors, and cancer had significant higher mortality as compared to the rest of the population they studied without this comorbid condition, where the mortality rate was around 1.5%. The mortality rate was somewhere between 7 to 14% for patients with cancer and cardiovascular disease or its risk factor. So, and again, when we combine this cancer and cardiovascular disease and some of its risk factor in our patients, that effect will be multiplicative, and that suggests how closely we need to attend to these people during this pandemic more than ever before. So again, this is kind of going stepwise. As we saw, it's 40% patients with cardiovascular disease in that area were affected with COVID-19. We have already gone through this, so I won't be repeating this. Now, these are the general measures probably we all should take, and we do take, but this is particularly important to educate our patients, those who are more vulnerable, to be aware, to avoid certain things, and to take actions. And these are widely available based on CDC and other recommendations. So I won't go into the detail, but it is very, very important to educate them in this regards. Now, I'll jump to a little bit of more specifics of outpatient cardio-oncology, what we are doing, and in fact, Dr. Lenihan and ICOS in general is leading effort into developing a wonderful document in this regards to guide the Cardio-Oncology Society worldwide how to deal with cardio-oncology issues in the era of COVID-19. And the leftmost column, at least on my screen, is in the red, is what if patient has COVID-19, and that's a constantly revolving area, so I won't dive into that, but basically the care is supportive with some antiviral investigational treatment. Considering telehealth is the key for all outpatient, whether cardiovascular disease or cancer. At least at this moment in Boston, and I believe in majority of the affected areas, we are continuing the anti-neoplastic therapy for the most part, after discussing the risks and benefits with all the involved parties, including the patient and their relatives and their living situation, and of course their oncologist. And we are providing them education. For very high-risk patients among this cancer population, those who are undergoing anti-neoplastic therapy with somewhat more immune modulation, such as immune checkpoint inhibitor or CAR T-cell or some of the other agents, or those who have had recent stem cell transplant, we are kind of quarantining them or recommending it to do that regardless of their COVID status. And so to the relatives or the household members of those high-risk cancer patients. The cardiovascular disease itself, we are trying to manage it as per the usual, as much as possible on the inpatient side, but we will see a glimpse of that in the later part of the presentation as well. Again, this is
Sarju, in regards to what you were just talking about, there was some recent data that came out from New York in the past week that the number of people that died at home in previous years was on average about 25 people that died at home. And then over the past week or two in New York, and especially in light of the COVID infection, that over 250 die at home. So whether that's truly related to COVID, which I think is unlikely, is probably more related to cardiovascular conditions that previously would have been managed where they're not coming for evaluation. And we've certainly seen many instances where somebody had severe chest pain and they tried to ride it out, not go to the hospital, and then finally they had to come to the hospital a few days later, and the deal was done. So, I think that especially for us in St. Louis, the the hospital that I work at is super busy all the time. Usually it's, over 100% census. And right now the census is probably 50%, and nothing really changed about the demographics of our patient population. It's just 50% of those patients that normally would have come to the hospital are at home. And I suspect that a number of them are dying there. So I think that this is a real issue because, as you point out, patients are going to continue to get their cancer therapy, and how are we going to manage that?
Yeah, as you said, nothing has changed. Otherwise, they are as cardiotoxic as they were in February 2020 or before that. And, we get phone calls not infrequently for new symptoms, but patients are afraid of coming, and appropriately so. And also when they present to the hospital, I think the focus of the entire, at least in my hospital and area, I know most of the hospital, as we are probably a little bit more overwhelmed with the COVID issues, is on COVID, and I have seen instances of delayed treatment for NSTEMIs, not for STEMIs so far, but while wasting time in COVID related issues, or waiting for the COVID test to come back and stuff like that, appropriately so, to minimize the exposure to the healthcare workers and the cath lab. But we have seen, unfortunately, adverse outcomes of those high risk patients. So the screening and surveillance, as Dr. Lenihan was suggesting, nothing has changed otherwise, and these cardiotoxic therapies are as cardiotoxic as they were before COVID era. And we all do this 3 monthly screening for HER2 agents and for anthracycline at baseline, and then after the completion of the therapy. However, we are deferring those routine surveillance echocardiogram for now. At least we are pushing 4 to 6 weeks down the line. We are doing the baseline echocardiogram. Whoever needs to start new anthracycline or HER2 therapy, we are doing their screening baseline echocardiograms. And if they need to just a surveillance echocardiogram, then we are kind of delaying them for time being. Now, there is a risk that we might be missing the early cardiotoxicity, cardiomyopathy, and heart failures because we are not seeing these patients physically, and also at the same time, we are not doing the echocardiogram. We are continuing their telemonitoring. However, it is not probably as good as seeing people in person. And this ICOS document is going to try to answer this question, whether can we follow patients with cardiac biomarkers such as troponin and BNP, and that's a $1 million question. Dan, do you have any comments on that?
Well, I think it's less than $1 million question, because if we were to do echoes, that would be $1 million. So
right.
The biomarkers are about 1/20th the cost of an echo. So I think that this, I believe, can be equivalently safe, probably even more so, and certainly more cost effective. And then and when you consider in terms of potential exposure to not only the patient but the sonographers, then I think there are many arguments for this particular approach.
Right. Now, do you worry about oversensitivity of the biomarkers, as we have been discussing this over the phone on the other group? And personally, I do believe that they are probably as good as echocardiogram for detecting early cardiotoxicity, as we have seen from many different chemotherapeutic agents, particularly anthracycline, but also HER2 and other agents. But do you think that mild elevation in these biomarkers may lead to actually more downstream testing or in-person visits, which would not have been triggered otherwise?
No, I would easily argue this one, that first off, a biomarker test whether it's normal or abnormal doesn't tell you what to do. It it's just a test. So it doesn't tell you how to manage the patient. So you have to figure out how to manage the patient. Number two, there are certainly many arguments out there that have been there for years about whether an EF measurement was sensitive or too sensitive, or whether we used strain and whether it was, you know, not as sensitive or more sensitive, who knows? But the bottom line is that the test had enough variation in interpretation that you could easily get an abnormal result, and then you had to put it in the context of the patient. And one of the things that Tom Suter, almost every single time we're on this topic, would argue is you need to repeat that EF at some near time interval, because most of the time that EF could either be just a transient change or a technical artifact. And so I would say that if you got a mildly abnormal biomarker, you know, you might want to check on the patient, you know, by telemedicine or whatever other tool you're using, and put it in the context of the whole patient. But it doesn't tell you to do something dramatic. You know, you may choose to augment their cardioprotective therapy, or you may choose to just repeat it in a few weeks. So I think that, you know, we can't get overwhelmed by general noise. I think that, you know, these tests are not intended to give you the final answer. They're intended to give you a screen for whether to look at the patient more carefully.
Yeah, I think that's a very good point, and I think we need to learn to ignore mildly elevated biomarkers in a way that not to ignore them, not to evaluate the patient, but to ignore them to the degree as we ignore abnormal GLS. You know, looking at the pictures, we many times say, you know, it's not even good 2D picture, so how are we going to rely on this abnormal GLS? And we don't act upon it. And similarly, I think we need to put the whole picture into the context. If patient was having neutropenic fever and just recovering from that, had a mildly elevated troponin before the next cycle or something like that.
Exactly.
So
I mean, there was a famous for me anyway, case that I was involved in a couple of years ago, where there was this young woman who had breast cancer, and she was getting, you know, she originally got anthracycline, and then she was getting trastuzumab-based therapy, and she had been getting it for 6 months or more. And her EF had always been basically in the normal range, but it was kind of in the low 50s, and it just kind of hovered there. And so she had gone more than 9 months into her therapy and had been generally doing quite well. She was going to have her breast reconstructive surgery, you know, like in the beginning of July of this particular year. And so right before her breast reconstructive surgery, she wanted to take a vacation with her family. So she flew to Hawaii and was having a great vacation. And her surgery was scheduled for 2 days after she returned. And the anesthesiologist who was looking at her on the pre-op list several days before her surgery decided to looked at all her echoes, and she had an echo the day before she left for Hawaii. So somebody interpreted the echo as an EF of 47%. And then the anesthesiologist was being compulsive and looked at all the data and saw this EF of 47%. And 2 days before she was planning on leaving Hawaii, the anesthesiologist called her and said, "We're canceling your surgery because you have heart failure." And you know, she was like totally fine and having a great time on her vacation. And so she cut off her vacation, flew back, and you know, came to see me the next day to say, you know, they canceled my surgery. You know, I don't know what's going on here. And I said, and I went and looked at the images, and the EF was probably better than 60. And the report had
Right.
read 47%. That was based on a technician's, you
Right.
know,
Right.
checking the endocardial surface and computing, you know, a 2D image or a 2D measurement of EF, and that's what came out on the report. And I mean, that is a prime example about how it doesn't matter what test you're doing, whether you're doing an EF, an EF measurement by whatever tool, if you're doing biomarkers, if you're doing a chest X-ray, whatever test you're talking about, you have to put it in the context of the patient, the before and the after, and with their overall medical condition. There is no automatic answer for every single test.
Yeah, no, I think that's a very good point, you know, and I read cardiac MRIs as well. And before I was trained for cardiac MRI, I always thought that, you know, numbers coming from MRI, especially for EF, are like, you know, coming from God. And after I started reading it, I realized there is a variation in that too, you know, making just 2 points here and there can make volume, you know, 5% change in EF could be easily, whether I had my coffee or not, you can make it. So even based on the highest precise.
Totally. Yeah, if you had 10 more studies to read and you were already late for a meeting, you know, you might read it differently than if you spent 45 minutes.
Yeah, absolutely. So you know, at least in this era, I think, and it's a good opportunity to try out the biomarker and their role routinely in our cardio-oncology patients as well. And of course, this is you know, we have to individualize the decision when we are making it for any patient, as Dr. Lenihan suggested. But kind of what we are considering the low risk patient is normal biomarker at this point, without recent within a year anthracycline or mediastinal radiation in 10 years ago, age less than 65, without any history of cardiac disease or significant risk factors, and no family history of cardiomyopathy, etc. You know, there are many factors to be considered, but these are the people who are considered relatively low risk in general for HER2 therapy related cardiotoxicity, and not that it doesn't happen, and but these are the patients where we can safely just use biomarkers and get by. Now, the other question comes in cardiology in general, but also in cardio-oncology more particularly, because many of our patients are on ACE inhibitor or ARB for either their prior cardiomyopathy or cardiac risk factors such as diabetes and hypertension both, or for primary prevention, they have been on it given, you know, prior abnormal biomarkers despite of normal EF, or persistently abnormal and kind of reduced GLS over the period of time, or if they are a very high risk patients to be considered. So yeah, sorry, Dan, go ahead.
No, I didn't say anything.
So and as we saw that this virus is using the ACE2 receptor as the entry point earlier. Now, ACE inhibitors and ARBs both can affect the pathway, the renin-angiotensin aldosterone pathway, in a way that would increase the expression of these receptors. And the concern has been that would that or could that lead to more severe presentation of COVID-19, such as acute lung injury or so on. And that has been a real question without a specific answer. However, you know, the data here is very insufficient. It is more theoretical based on the lab experiments rather than any real clinical data. All the major societies, including American College of Cardiology, AHA, as well as European societies, have came out against abrupt withdrawal of ACE inhibitor or ARB in patients living either in the high transmission areas of COVID-19, with the fear that, you know, they are more likely to get, or when they get it, they are more likely to have severe disease, And we kind of agree with that recommendation, because the data is actually even conflicting to some degree, because there are ongoing trials of some of the ACE2 modulators and ARB, particularly losartan, that if the receptors are modulated in a favorable way, then that can actually help the COVID-19. And there is no evidence to prove that as well so far. All what I mean to say is the data is very limited and it's very conflicting, and hence we do not recommend abrupt withdrawal of ACE inhibitor or ARB in patients, those who really needed it before COVID era. Of course, if they're in the hospital and hypotensive and they need to stop for good reasons, that needs to be done. But until further data is available from either clinical trials or retrospective subgroup analysis of the large cohorts, I think it's reasonable to continue with this therapies. Now, cardiovascular symptoms and troponin elevation in COVID-19 patients. This is very tricky situation, because many of our cardio-oncology patients have this thing regardless of the COVID-19. Many of our patients have atypical chest symptoms and mild troponin elevation for other reasons. Now, if they have COVID-19 or they live in the area where the COVID-19 is highly prevalent, this certainly raises more questions than before the COVID era. And again, this is not specific for cardio-oncology patient population, but this is in general for any COVID-19 patients. If they have typical or atypical cardiac symptoms and troponin elevation, if they have either suspected or confirmed COVID-19, and if they're in the hospital, this is what we are doing. We are doing the ECG, of course, telemetry, and we are trending troponin until it peaks, which otherwise we may not have sometimes. We are not getting routine echocardiogram for mild troponin elevation without significant, if patient is unstable or troponin is significantly elevated or have significant cardiovascular symptoms, that's a different story. But just for the mild troponin elevation in otherwise stable patient, we are trying to avoid unnecessary testing to minimize the exposure to the sonographer and healthcare workers in general. Now, there are a variety of mechanisms proposed, and probably it's really hard to tease out, but I'll at least in theory try to explain these mechanisms, and it's not easy in practical life when you see this patient to say what exactly is causing this issue. Myocarditis, that's one, so direct toxicity through the viral invasion into the cardiac myocyte. And that's been reported in the COVID patient. Patients with COVID-19 have reported to have abnormal cardiac MRI suggestive of myocarditis, along with other classic clinical features of myocarditis. And it improved with COVID-directed treatment. ACE2 mediated cardiovascular injury, as we just saw multiple times, ACE2 receptors is widely expressed and important for the viral entry. Cytokine storm, as we saw, in any ill patient, but particularly certain infections are more likely to cause cytokine storms than other for a variety of reasons. This is similar to CAR T-cell therapy related cytokine storm as far as we understand based on the early mechanistics, and it is IL-6 is playing a significant role in that. Or a plain old stress cardiomyopathy, as we would see under any stressful situation, or type 2 myocardial infarction in patients with history of prior cardiac disease or significant risk factors, those who may have underlying cardiac disease, as we see in other situations as well, or a real acute coronary syndrome in patients with COVID-19, as Dr. Lenian was suggesting. There is nothing has changed just because COVID came. The people, those who are going to have STEMI or NSTEMI, they are not going to stop having them. But it is possible that either they may ignore or we may misinterpret their symptoms in the COVID era. So we really need to walk through the possible mechanisms. Now, as I said, the COVID-associated myocardial injury, it's really hard to tease out what is causing what, and we'll dive into that into a little bit more detail. But they usually have atypical symptoms or no symptoms. Troponin typically rises few days later. So at least in one study, they showed that COVID-19 associated myocardial injury, troponin rose 4 to 5 days after the hospitalization. In severely ill patients, it was slow to rise and slow to come down compared to acute coronary syndrome. So these are some of the differentiating features we may use in addition to, of course, the clinical picture. They may not have ECG changes as we would see with acute coronary syndrome or stress cardiomyopathy. And they may have other stigmata of, the cytokine storm, which may direct to the cytokine release syndrome related myocardial injury, as we see in CAR T cell therapy as well. And we really have advantage here as a cardio-oncology community to be familiar with that from a CAR T era we live in compared to the other cardiologists even. Stress cardiomyopathy, I don't need to go into the details of that, but as we know, they may or may not have cardiovascular symptoms, may have clinical heart failure, troponin may not be very high, and ECG may show whatever it shows typically. And the treatment is mainly supportive. We may consider limited echocardiogram. We have to consider limited echocardiogram in these scenarios if they have clinical heart failure particularly. But again, it may end up showing, Takotsubo pattern. Now, it is a diagnosis of exclusion. However, I think this is our opportunity to, step up to the game and make a real diagnosis. And if it is hard, what we are at least trying to do in patients where we feel compelled to rule out coronary artery disease, we are using coronary CT angiogram more than our cath lab. Of course, needless to say, in hemodynamically stable patients and etc. But that's another tool which is somewhat underutilized. We could leverage that. Type 2 myocardial infarction, again, they may not have symptoms, troponin may be low, ECG may not have significant changes, or maybe more global pattern rather than a particular distribution of the coronary artery. And again, the supportive care with outpatient follow-up, they don't need echocardiogram all the time if they don't have symptoms or clinical heart failure or mildly elevated troponin. They don't need typically echocardiogram, although in usual circumstances we may have done. I think we may safely avoid them. And ACS, as we all know, immune checkpoint inhibitors and CAR T cell therapy in COVID-19 era, and this is the ICOS document which is under preparation with Dr. Lenihan and Dr. Neelan and Dr. Yorg and others, is going to address this issue in detail. However, this is the preliminary thinking here that, as we all know, the immune checkpoint inhibitors are widely used and can cause myocarditis themselves. Now, speaking of viral infection, this is not specific to COVID-19, I would like to specify, but in general, any viral infection can increase the expression of PD-1 and L1, right, which we are trying to block. Similarly, CTLA-4 agonist can support the immune response as well, at least in theory. And when we are blocking these pathways of immune response mounting with immune checkpoint inhibitor, we don't know the impact of it, the clinical impact of it. However, something need to be aware of, that they may have some impact, or at least the adverse impact. And so any patient receiving checkpoint inhibitor, if they present with elevated troponin, of course, we need to consider checkpoint inhibitor associated myocarditis. However, we need to keep in mind that the incidence is relatively low and it's less than 2% in combination therapy. And we need to rule out the COVID-19 co-infection, which might be contributing to mild troponin rise or other, even myocarditis itself, if seen on MRI. And even before we send them to MRI and for further testing, we need to rule out COVID-19 to limit the exposure and unnecessary testing both. Similarly, CAR T cell therapy, however, this is used much less widely than immune checkpoint inhibitors, only at certain centers, but that can cause cytokine release syndrome, very similar to what we are seeing with COVID-19, leading to lung injury, myocardial injury, and so forth. And so for any patient with CAR T and experiencing cytokine release syndrome, it will be prudent to rule out the COVID-19 infection at the same time, and kind of have a lower threshold to use anti-IL-6 agents such as tocilizumab, I'll tell you, at least where I practice, the threshold is very low to begin with. I don't think it will probably go even lower, but I know the centers, very good centers, where they have, for good reasons, a little bit higher threshold to use tocilizumab, and appropriately so for good reasons, at least in theory. And those people and centers may need to consider, at least ruling out the infection and probably lowering the threshold a little bit more. We saw COVID-associated myocardial injury a little bit before, and this is our approach. And again, this is not anything validated or something we have established at an institutional or multi-institutional level. Is again, for stable patients, we are considering virtual visit even when they are admitted in the hospital, and we don't do any cardiac MRI routinely or other testing, and just follow up as an outpatient, versus people, those who have symptoms or high troponin or arrhythmia or unstable. Of course, we see them in person with appropriate personal protective equipments, which is another burning topic, and we could spend probably a few hours on that. And again, we are avoiding cardiac MRI or endomyocardial biopsy in these patients where we think it's a COVID-19 related issue. There was one patient we had who we initially thought had COVID-19 related myocardial injury in a 40-some-year-old female, and ended up having eosinophilic myocarditis. As we were discussing before, just because COVID-19 is occurring doesn't mean that the other issues will stop. And her COVID testing was negative on 3 different occasions, at least 24 hours apart from each other, in different labs by little bit different techniques. And she did not have other stigmata of COVID, and other than a little bit of heart failure symptoms, which were initially chest X-ray was attributed to, suggesting of possible COVID, but she ended up having a different issue. So, after a certain point, we did consider endomyocardial biopsy and cardiac MRI in her, but at least, that's probably not her day-to-day case. And, supportive care, tocilizumab, which is kind of getting in the shortage, and at least we need a multidisciplinary approval at our institution. IVIG, it is mainly case report based evidence, but I think it does make sense logically, so something to be considered for patients with severe COVID-19 related myocardial injury. Steroids are tricky. WHO and major organizations have kind of recommended against the routine use of steroids. However, that does not account for cytokine release syndrome or myocarditis type of picture. So I think we need to apply a little bit more logic and our experience from either immune checkpoint inhibitor myocarditis or CAR T-cell related cytokine release syndrome, that steroids are useful in hyperinflammation state. But I think fairly, WHO and other organizations have said that don't use it routinely, at least early on in the infection, because it can actually exacerbate the infection, and that's fair. But we don't need to rule them out in the hyperinflammation phase. And again,
I think that it's very nice to formulate a figure like this, because it kind of gives people a general construct to work with.
Mm-hmm.
But just the case that you're talking about, but many other cases that I could cite, it is so difficult to figure out what's going on in people with suspected myocarditis that, whether it's due to a viral syndrome of some variety, of which COVID would just be one. There are many others that could cause myocarditis. Whether it's related to a checkpoint inhibitor if the patient was on it, or whether it was a non-ST elevation infarct, all of these things are extremely difficult to tease through. So it's pretty hard to even in a general way kind of put a simple one-page construct for how to do that. And in the case of eosinophilic myocarditis, steroids are the preferred treatment. So,
right.
I think if that's what the diagnosis that you came to, then that
Yeah.
would be the right treatment.
Yeah.
On the other hand, if you're still trying to figure out if it's COVID, then probably not a good idea.
Yeah.
On the other hand, if it is in association with a checkpoint inhibitor and you do the various things, and it does appear to be myocarditis from a checkpoint inhibitor, then you and Tom Nealon and others have shown that early steroid at high dose is the appropriate treatment. So you can just imagine, when you're faced with all of these possibilities, where one of the possibilities is don't use steroids, another possibility is steroids are the preferred treatment, and a third is early and very high dose steroid is the only treatment that's been effective. So, those are widely disparate practice recommendations.
Yeah.
And the same patient could have any of those things. So I just think this whole space is really complex, and we need to learn from each other on these issues. And I don't think that you're not going to be able to make it a simple one-page diagram. It's just too hard.
Absolutely. I think this probably is somewhat more, it is still very hard, as we saw in couple diagrams above, that there is a wide differential, even if we don't consider the cardio-oncology issues here, such as checkpoint inhibitor or anthracyclines or CAR T cell. It is wide variation of diagnosis in general, and it's really hard to tease out. And if we add the complexity of our cancer therapies on top of it, I think it is impossible. It is very likely that at least I will make wrong diagnosis, and despite of all the theoretical knowledge we may have, it's impossible to know. And I think you just have to go with. But I think we need to just make sure that we think of COVID-19, and if patient is COVID-19, we try to minimize the exposure to other patients and healthcare worker. But at the same time, just because they have COVID-19 does not mean that they have a death sentence, and we don't take care of the other issues they have. But I think we just need to be mindful of this. I think that's all what we can say. And these are the potential treatment trials. I mean, we can use them as a trial treatment is tocilizumab, IVIG, steroids, etc. And it's trial and error world, unfortunately, at a high cost.
Well, and then the other thing that you talked about on a slide or two before was, the current day management of acute coronary syndrome at our hospital has, it's kind of gone back to the future. I mean, in many instances, we're considering whether to give thrombolytic therapy as opposed to taking them to the cath lab. Now, we did that a lot when I was a resident and a fellow. And that is, I hate to tell you, was in the previous millennium. So, this is a different practice pattern than what has happened in the United States in the last decade or 15 years at least. So, I think it's great because those medicines were good. They were very important. But then the fine details of how to give them, what dose to use, whether to have, heparin or Lovenox or some other anticoagulant in the background, all of these details are extremely complex.
Absolutely. And this is what we are using at our institution. This is probably one of the last slides is, for stable STEMIs or unstable angina, we are trying to, medically manage them if possible without, even getting echo or stress test. And again, this is purely for stable patients. They don't have clinical heart failure. They're not unstable. They do not have arrhythmia, etc., and they improve with the medical therapy. However, if they have any of those, or of course, if they have STEMI, that bypasses the whole thing, And one caveat we have added is any young patient, without significant history of CAD or risk factors, we are considering the STAT coronary CT angiogram, which we may not have otherwise in many cases. We are making sure that they don't have pulmonary hemorrhage, as much as we can. It's not easy to do, but at least kind of looking for the signs of it if they have a chest imaging. And not that we are waiting for chest imaging to come back, but something to be considered if they have already CAT scan or stuff like that. And if they have impending respiratory failure, then we are intubating them before coming to the cath lab, which we won't have care otherwise. In a normal day, we'll take care of everything in the cath lab with anesthesia and so on, to minimize the exposure in the cath lab, because at least our cath lab is not a negative pressure room. Any of our 6 cath labs are not negative pressure rooms, unfortunately. And that may not be the case at every institution, but I believe many institutions, cath labs are not built for isolation or for COVID era.
And I think the time factor is very important here. That at one point when I was in private practice, I would be at a small community hospital that was, say, 45 minutes away from a major center. And if somebody came there with a impending or developing acute myocardial infarction, it would be very frequent that I would give thrombolytics. And then there was a point in time where we gave like half dose thrombolytics and sent them to the cath lab.
Right.
The cath lab took an hour to do.
Yeah.
But here in this day, even coming to WashU in a major city, et cetera, it might take 2 hours or longer to get a patient from the ED into the cath lab. And even then, you're going to expose your whole team to the whole COVID possibility. That if you can give thrombolytics early and manage that problem, getting a therapy in within the first 60 minutes, then that's probably overall better for the patient than trying to figure out how to get them to the cath lab. So I think that
absolutely
it's a new era. You have to think on your feet, and some of these tried and true therapies that didn't seem to be all that important to us at this point in time actually are pretty important.
Yeah, absolutely. And it's again something cannot be generalized, and every institution needs to, depending on their resources, their structure of the cath lab teams, etc., need to figure out on individual basis. I'll tell you, we have been, at least I was on the other call with other Boston colleagues, and what they are doing, trying to understand at their hospitals. At least they're all trying to still pursue primary PCI, especially if they have the PPEs available. Granted, otherwise we are not going to be able to take people to cath lab if we are not given appropriate PPEs, and especially sick patients, those who may need CPR, intubation, etc. So that's another limitation as well. Despite of how well prepared we are or how quickly we can get patient to the cath lab, the availability of PPE, which we know is a nationwide shortage or a global shortage, is another factor to be considered at an institutional level. But at least so far, I know in the area, hospitals have still been considering the primary PCI as the primary modality. The average time has been less than 45 minutes, including the preparation of the staff with all the appropriate PPEs or pepper, whatever we consider at different institutions. And I think one thing.
So I did want to, I know we only have 1 more minute left, and I wanted to go back to one question, which at least has bothered me, but can you go back on your slides to the part about the ACE receptor and all of that? So, I feel like this was or is much ado about nothing. Now, I don't know if that's true or not, but because I'm not sure I understand the mechanistic considerations at the angiotensin II receptor level and all that. But it does make me think, you know, years ago we had this 3 to 5 year argument about whether aspirin attenuated the effects of ACE inhibitors in people with heart failure. And, you know, I think that was completely off the rocker, you know, and in the end, people started to stop talking about it, which is good. What is your take on this whole ACE ARB potential interaction?
Honest answer, I don't know, to be honest with you. I think it is a whole lot of nothing, as you said, you know, because and I think even the retrospective data is going to show some association, because not because the ACE inhibitors or ARB cause harm, but I think it is because, you know, those people who are on ACE inhibitor or ARB are more vulnerable to get infection and have worse outcome in general, you know, not just of COVID-19, but any other infection. You know, if you take patient with heart failure with EF of 35% getting, you know, MRSA versus young guy with EF of 65% getting MRSA and, you know, bloodstream infection, of course, you know, EF of 35% is going to do worse, but not because he was on ACE inhibitor, you know, because he was sick to begin with. And I think that's what we are going to see. So I think it's going to be really hard to tease out, but I agree with you, you know, clinically, I don't think it is anything significant concern, at least at this point.
No, I think I would be very careful about that, because, you know, just as important as ACE and ARB are to our general patients and practice in general, that, you know, just because there was one little news report on the internet about, you know, some sort of interaction, you know, I've had a number of patients who called me or emailed me and asked me, should I come off my ACE inhibitor? And I'm like, no, don't do that.
But yeah, no, I had a patient who called me and informed me about the losartan trial. So patient was on Entresto and said, you know, should I start losartan instead of Entresto? And I'm like, based on what, you know? And then she pointed out that they started some trial on losartan to see the positive, you know, modulation in a positive way. And I said, no, you know,
yeah, so, no, that forgets the last 10 or 15 years of heart failure research. So
right. So
now, Sarju, thank you so much. You've done such a fantastic job, as you always do, and congratulations on your recent paper. I know you have many others, but we really appreciate you coming on and sharing your experience and expertise. And you know, we look for what you can teach us in the future.
Well, thank you so much for having me, Dan, and Stu, and you know, sharing the platform with such a wonderful audience. So thank you so much.
All right, thank you all for attending. And Steve, I don't know if you have anything else to add.
Just a reminder that we're doing weekly webinars now. So each week at this time, we'll have a different webinar. Next week, it'll be topics in cardio-oncology, and there'll be a presentation from the team in Israel on comparing GnRH agonists and GnRH antagonists.
Fantastic. Thank you so much. Appreciate everybody's participation.
Thank you all.
Thank you. Stay safe, everyone. Take care.